So I thought it'd be really helpful to get a speaker, and fortunately, I was able to find Andrea McCart, who's a surgical oncologist from Canada. And so she's had actually a somewhat similar background to me. She was at the NCI, the surgery branch, doing research for 4 years, and 1997 to 2001, is that right? Yeah. And so she had a lot of experience from the surgical oncology side, and she worked with Dr. Bartlett in peritoneal malignancies and has developed an interest, and now she's back in Toronto, as an associate professor in the Department of Surgery at the University of Toronto, and working as a research scientist as well, investigating peritoneal malignancies. Now, generally we're focusing on pleural disease, but basically the disease is very similar and has a lot of parallels, so I think it'd be great if we can learn about that. So I invited her to come and educate us about oncolytic viral therapies in mesothelioma. So Dr. McCart. Only the laser is heavy. Okay. And this is the advanced thing.
Okay. Well, thank you for inviting me to talk today. I don't have any financial disclosures. I was going to disclose that I don't work on pleural mesothelioma, but he gave that away already. So I'm going to talk to you about preclinical work that we've been doing using oncolytic viruses for peritoneal mesothelioma. An oncolytic virus is a virus that is that's replicating, but only can selectively replicate in tumor cells and not in normal cells. And generally speaking, they can be engineered to deliver therapeutic or imaging genes, and also can be used either locoregionally and or systemically. So if you just think about cancer and viruses, the way that a normal non-cancerous cell gets rid of viruses is by undergoing cell cycle arrest, apoptosis. It suppresses the viral genes and suppresses angiogenesis. But when that is, generally speaking, all lost by a tumor cell in its process of becoming cancer. And so viruses in general love tumor cells and can replicate like wildfire there. Oncolytic viruses, over the past few years, they've always been known that you can directly infect tumor cells and kill them with the virus. But what we've learned over the past couple of years is that they can also infect the tumor vasculature surrounding a tumor, so it can shut down the vasculature and cause tumor necrosis because of a lack of blood supply. And then also during the process of infecting the tumor cell, the viruses kill the cell, release tumor antigens, and can cause an anti-tumor immune response, as well as the antiviral immune response. So we specifically in my lab use Vaccinia virus, and Vaccinia virus is the virus that was used as a smallpox vaccine, so it has a very well-established safety profile. It's a cytoplasmic virus, so it's safe, it doesn't get incorporated into the genome, replicates very quickly. It's actually a very large virus, but that means you can delete genes to make it more tumor-specific and add in genes like immunomodulatory or imaging genes, which I'm going to talk about. And this is just showing you some of the effects of the virus in our models. So when I was at the NCI, we created this double-deleted virus, which is now in clinical trials, but it's deleted of its thymidine kinase and Vaccinia growth factor genes, and as well contains a red fluorescent protein for mouse imaging, and also, I'll talk about it at the end, the somatostatin receptor for nuclear imaging and therapy. And this is just 2 different models of peritoneal carcinomatosis, ovarian, and colon cancer. And you can just see when we infect the mice with the virus that only the tumor cells express the red fluorescent protein. All the normal bowel and other abdominal organs are all spared, as we were hoping. And the way that these, for the double-deleted Vaccinia virus, It's in a normal cell, in a normal situation, wild-type virus infects the cell, makes the viral TK, which creates a nucleotide pool, expresses the viral Vaccinia growth factor, which sets off the EGF pathway, and also stimulates nearby cells to start dividing so that when the virus is released from the cell, it can infect surrounding cells. But that does not happen. So in the double deleted virus, it's missing the VGF and the TK, so it can't set the system up on its own. But luckily, in a tumor cell, this is already, the EGF pathway is almost always constitutively activated, and so the virus does not need these genes, and that's what gives it its tumor specificity. So I'm sure you guys know a lot about pleural mesothelioma. As Dr. Cameron said, peritoneal mesothelioma is very similar. It's quite rare, but it's thought that the incidence is still continuing to rise. Currently, surgery is the main treatment. The chemotherapies that are used for pleural mesothelioma are only occasionally effective in peritoneal mesothelioma. And unfortunately, generally speaking, people fail because of recurrence in their abdomen. We treat patients with peritoneal mesothelioma with cytoreductive surgery and heated intraperitoneal chemotherapy, but many patients, by the time they present, are often have too advanced disease to be able to undergo that kind of therapy, and that's why I've been working on this in the lab to develop new therapies. So the goal of this project was to evaluate Vaccinia virus to treat different models of murine peritoneal mesothelioma, and also to evaluate its potential role as an adjuvant treatment to debulking surgery. So we did some in vitro studies to begin with, and the murine, these are two murine peritoneal mesothelioma cell lines that were developed by injecting asbestos into mouse abdominal cavities, and then they formed cell lines from them. And then our control line is a murine fibroblast line. And so this is just increasing doses of the virus along here. And you can see in the normal cell line, we have very little, the little white dots are where the virus is infected. Very little infection in the normal cell line. But as you increase the dose of virus, the peritoneal cancer cell lines are both really wiped out. This is shown again here, the virus, oops, sorry. So this is a MTS assay which measures cell viability. So the in vitro, the cells, the same cell lines are infected with different doses of the virus. And so as you can see, the normal cell line here in green does not really get killed by the virus, which is a good thing. Whereas both cancer cell lines, as you increase the dose, this is over 72 hours, are basically wiped out by the virus. So next we developed these peritoneal models of mesothelioma. In the AC29 model, so in both cases, the tumor cells are injected intraperitoneally, and then this is 10 days after the tumor cells were injected. And in the AC29 models, you can see these giant coalescing tumors, and actually the mice also develop large amounts of malignant ascites. And in the AB12 model, it's actually quite different, but it's actually very representative of what happens in humans because you can get both patterns. In the AB12 model, you get all these tiny little tumors all over the place, and which generally results in multiple bowel obstructions and no ascites. So it's very, lots of tumors, but very different models. So to begin with, we just injected, so the tumors are given, and then when the mice have had tumors for 10 days, we inject the virus intraperitoneally or a vehicle control. This is in the AC29 model, and you can see that compared to the vehicle control where all the mice have died by 40 days, just with virus alone, we have 30% long-term survivors. And in the in the AB12 model, which is more difficult to treat because of developing bowel obstructions, I think, we do have an improved median survival, but did not result in any long-term cures. We also looked at, in these mice, where the virus went. So this is at 72 hours after viral delivery. We looked at a bunch of different organs. You probably can't see the axis too well, but this is tumor and ovary. And in both cases, we saw a virus in tumor and ovary. And ovary is a common place in mice for Vaccinia to grow. It doesn't really happen in humans. But you can see spleen, kidney, liver, bone marrow, brain, bowel, heart, lung. You don't see any virus in normal organs. And so we wanted to combine the viral treatment with what we do in patients, which is basically a 95% surgical debulking before giving chemo. So the mice either had a sham surgery, which was just a exploratory laparotomy, and then the mice, the degree of tumor burden was measured using a peritoneal cancer index, which was originally described by Dr. Paul Sugarbaker, but was modified by Janssen for the mouse model. And basically the abdominal cavity is divided into 13 quadrants and given a score of 1 to 3, depending on the size of the tumors. So the mice had their PCI calculated before and after surgery. In the mice that had the debulking surgery, unlike humans, we can't resect bowel and put it back together, so it really limited the amount of surgery that we could do. But basically, tumors in the parietal peritoneum, omentum, parametrium, and pelvic peritoneum were all removed. But overall, in both models, we were only able to achieve, based on the PCI, about a 55% reduction in the AC29 model and 60% in the AB12 model. And then this is just showing you befores and afters of the surgery. You can see all this white tumor has been cleared out after the debulking. But unfortunately, maybe the Vaccinia virus by itself is too good, I'm not sure, but you can see that the black dotted line here in both cases is just the sham laparotomy. And basically every treatment is better than nothing, which I guess is a good thing. But surgery alone here in the black line, virus alone here, again, leads to about 30% survival. But in the combined group, we didn't get any extra benefit of combining the surgery plus virus. They basically are equivalent. So we're not really sure what the cause of that was. Obviously, mouse models are very difficult in terms of surgery. They're unhappy for a few days, and after they get the virus, they're unhappy for a couple of days. So it may be that the combined sort of insults made them too unhappy. But also, we know in patients, if you can't get a 95% debulking, like a half debulking like this is actually worse than not operating. And I think it's because of the immune system suppressed, and cancer loves all those factors that are coming in to heal the surgery. So that was our hypothesis, anyways. So then we decided to use this is an artificial model of a complete debulking, but basically we treated the mice 3 days after they had tumor. So basically they had no visible tumor, just microscopic disease, no surgery. But you can see that if you can treat the mice with microscopic disease, eventually the mice that had no treatment all died. But we had 50% long-term survivors in the mice that got virus. So, I mean, it is a promising modality for microscopic disease. So if you could get your patients to that state, I think it would be worthwhile. So, as I said, it wasn't really a home run for surgery. And even then, with the virus alone, we're only getting long-term survival in 50%. So we have been working on different ways and in different models to improve the effects, and one of those ways is combination therapy. I'm not going to talk about combination with chemotherapy today, but I'm going to talk a bit about what we've been doing with targeted radiotherapy. So as I mentioned before, the virus also expresses the receptor for the somatostatin receptor. And I don't know how common this is used for thoracic malignancies, but in abdominal neuroendocrine tumors, octreotide scans and labeled octreotide are used for malignant neuroendocrine tumors. This is a cousin to octreotide 177 lutetium dotatate, which is what we're using in our mice. And you can see in these neuroendocrine tumors that you can nicely image the tumors based on their receptor positivity for the somatostatin receptor. Many somatostatin analogs have been developed for tumor targeting, and radiolabeled somatostatin analogs are the only radiopeptides that are currently approved for use in North America, and they can both be used for diagnostic imaging, treatment of the tumor, and also post-treatment imaging. The downside, though, is this right now is limited to tumors that express the somatostatin receptor. So we thought, what if you make your virus express the receptor? I've already shown you the virus goes in and specifically infects just the tumor. So if the virus, wherever the virus lands, you get the receptor, then maybe you can target the receptor with the radiolabeled somatostatin. So this is a paper we published a few years ago now, just for imaging purposes. And this is mice who had flank tumors, actually colon cancer flank tumors. And, but you can see in the mice that were treated with the Vaccinia expressing the receptor, we were able to image that flank tumor, whereas in the mice that got the control virus, it did not show up the tumor. The kidneys, the somatostatin is secreted through the kidneys, and so that's why the kidneys light up in both cases. And actually, it's interesting, just in 2013, a similar study was done in pleural mesothelioma in mice with a different Vaccinia virus. It's a different strain of virus, and also, in this case, the virus expresses a sodium iodide symporter gene, and then the mice are treated with iodine 131. But you can see that in these the pleural cavity mesothelioma deposits are able to image the pleural mesothelioma. This is not a mesothelioma model, I confess. It's a colon cancer model, but similar idea. We give intraperitoneal colon cancer cells, and then 12 days later deliver the virus that's either expressing the somatostatin receptor or control. And then 6 days after the virus, we give the radiolabeled dotatalk, which is the somatostatin analog, and then evaluate the mice for where the virus is detected on nuclear imaging, toxicity, and survival. So this is basically a nuclear, like a CT SPECT of a mouse. I'll just show you over here. Both mice have widespread carcinomatosis, but this mouse got a GFP virus that does not express the somatostatin receptor, and you can see that while we see the kidneys where the somatostatin is excreted, you do not see the peritoneal tumors lighting up, whereas in the mice that got the virus with the somatostatin receptor, as well as the kidneys, you see all the little tumor deposits lighting up where the virus was replicating and expressing the somatostatin receptor. And then lastly, this is a very busy survival curve. I should say I didn't show the slide, but we did not see any toxicity with the combined therapy. We looked both at blood counts after the targeted radiotherapy and weight loss, and there was no toxicity. So the curves of interest really are, so the mice that got the somatostatin receptor alone had a 40-day median survival, which is this green line here. And the mice that got the combination of the high-dose DOTATOC plus the virus is this light blue line here. So it increased the median survival from 40 days to 70 days. So, and this GLD1 colon cancer model is relatively resistant to virus therapy. So it actually was a big improvement in survival in this model. And so our next, some of our next plans are to move us into our mesothelioma models. In conclusion, we've seen that Vaccinia virus effectively kills mesothelioma tumor cell lines in vitro and improves survival in the animal models of mesothelioma. Unfortunately, the combination of surgery and virus is not superior to virus alone. But the high efficacy of the virus in the microscopic disease context suggests the use of the virus as an adjuvant, and since we've shown it has efficacy in multiple animal models, I'm hopeful that it can be developed for use in humans. And in fact, Valerie Rush, I think, has a Vaccinia trial going on right now. It's a different virus for pleural mesothelioma. And also future treatments will hopefully include a combination with targeted radiotherapies. So needless to say, as a surgical oncologist, I didn't do any of this work. This work was done by my people in my lab. Sergio did the majority of the work. He's a future surgical oncologist. And Bismira and Nan did a lot of the in vitro work. And that's just my lab and our funders. So thank you very much.